They take your blood test and then they compare what you are to what is called the normal range. What is deemed the normal range is just we take a group of people from the street and then we plot that into a graph and then we say, right, the outliers, the top and bottom 5% are the abnormal and the rest is normal. Now the problem with that is that the people that we're saying are normal may not be. They might actually be very ill walking on the street. So all we're doing is instead of saying, well, what's the normal range, is we're just saying what's the common range in the population today. But as we know, we don't necessarily have a super well population. Hello and welcome to PCOS Explained, formerly the PCOS Nutritionist Podcast. I'm your host, Claire Goodwin, a registered nutritionist and exercise scientist, specialising in PCOS because I have it too. Each week, we'll uncover the latest research, share inspiring stories, and provide practical tips to help you thrive with PCOS. Whether you're newly diagnosed, you've been struggling with this for a long time, or supporting someone with PCOS, this podcast is your go-to resource for empowerment, education, and community. So join us as we uncover the tools to thrive with PCOS. PCOS Explained is brought to you by our very own service, Ovi. Ovi is your go-to health service for women with PCOS. We help you improve your PCOS symptoms and prevent the long-term complications of PCOS by giving you hyper-personalised health advice based on your specific symptoms and PCOS drivers. We have a range of plans to suit your needs, from a DIY app-based program to one-on-one consultations. You choose what suits your budget and learning preference. And we offer a result-based guarantee on our Premium Plus plan, meaning that if we don't help you achieve your goal, we refund your money. Ovi is available worldwide, so it doesn't matter whether you're based in the UK, US, Canada, Australia, New Zealand, or anywhere else, we can still help you. So today's topic, we're talking all about why are my tests normal even though I do not feel normal? And this is, oh my gosh, the amount of times that I could have screamed when I, in my health journey, would go to the doctor, be so excited because I found out there was something that could explain my symptoms, go to the doctor, get tested, and then waiting for her call to be like, oh my gosh, yes, you were right, we found this is what's going on, and this explains all your symptoms, only to just get no response, and then finally after 2 weeks ring up the doctor's clinic and they're like, oh yeah, they're all normal, nothing to be done. And then being back to square one of being like, I still don't know what the problem is and therefore what I can do about this.
Yeah, I think we put so much faith in blood testing being a clear insight, like an x-ray into our body, but it's no, there's only so much blood tests can do for us and so much that they can show us. And I think understanding the accuracies or the parameters around the different blood tests to understand how much we can rely on them is so important.
Yeah, definitely. Or even just, as we're going to explain now, that maybe those tests weren't taken at the right time, or maybe the wrong thing was measured, and or just the reference range is way too big. So there are so many reasons why you might be getting a normal test result even though you do not feel normal, you feel very unwell or very suboptimal, and why that could be. But again, don't worry, this doesn't mean that there's nothing that can be done. It's just that you might need someone to look at it with a different lens or look at some other symptoms as opposed to just that blood result. Yeah,
well, recognise what blood tests actually might be more relevant with what you're presenting with, and they weren't actually taken in your first lot, so could we have a look at these ones maybe?
Yeah, definitely. So first reason why your test might be coming back as normal even though you don't feel normal is that the way that's being analysed is that they take your blood test and then they compare what you are compared to what is called the normal range. So how they come up with the normal range is, if any of you have done statistics before, you'll understand the bell-shaped curve where we plot the population into a graph, and generally what comes out is that it's a curve. So you've got the majority of the population fall within 90% of the curve, and then the edges is what's called the outliers. And so the same thing happens with blood tests, is that what is deemed the normal range is just we take a group of people from the street and then we plot that into a graph, and then we say, right, the outliers, the top and bottom 5% are the abnormal and the rest is normal. Now the problem with that is that the people that we're saying are normal may not be. They might actually be very ill walking on the street. And so all we're doing is, instead of saying, well, what's the normal range, is we're just saying, what's the common range in the population today? But as we know, we don't necessarily have a super well population.
Yeah, especially when you think about like the percentage of, while I hate using this term, but like obese people in the world is like hugely evolved or shifted over time. The percentage has increased and increased and increased in the last 50 years or 100 years, say. And so our blood test parameters kind of just shifting with that range, and are we just kind of allowing more abnormal to be the normal? And is that actually optimal, how our body actually wants to function, or is that just what we're seeing in population?
Totally. And a really good example of this was when I was pregnant, my obstetrician, I was talking to her about the gestational diabetes test, and I got my results back because I said to her, I want to get an early test because I know that I have been insulin resistant in the past, and I'm predisposed to this. So we got an early test, and I was talking to her about the results because I got the results and I was fine. It was well within the range. But I said to her, I was like, oh, this range looks really like high, because I work with people all over the world and I know the different ranges all over the world. Ours looks really high. And she said, yes, it is. Do you know the reason for that? And I was like, no. And she's like, well, so in New Zealand, and again, I haven't fact checked this. This is purely what she has told me, but she is an obstetrician, and so I trusted her. And she said a few years ago, we couldn't keep up with the number of people that were attending gestational diabetes clinics. And New Zealand as a whole didn't have any additional kind of funding, because New Zealand is a public health system, and so we have to have funding to do everything in health. And so she said we couldn't keep up with the demand, and so we just had to increase the reference range. So we were only dealing with the most severe cases. Just like flabbergasted by this. I was like, this is outrageous. So that basically you're telling, I don't know what percentage, but a big chunk of people that they're
blood
not
fine.
Yeah, that they're absolutely fine, and they're none the wiser. And like with gestational diabetes, we know that if you have gestational diabetes and it's left untreated, 50% will go on to develop type 2 diabetes in the next 10 years. So like this is
and the metabolic effects for the baby
totally
too.
Yeah. And so it's like, that's one example of where it's not necessarily normal or optimal, but just kind of common, or, well, we're only going to treat the most severe cases. So if you're not the most severe, then we're going to have to leave you, right?
Yeah.
So, a shocking example, but an example nonetheless. That's kind of like the normal versus optimal there. But then there's also two, normal versus optimal, and what's optimal for you at a certain time in your life. So, for example, the ferritin range for women, for example, would say that you've got normal ferritin if your ferritin, otherwise known as kind of your iron storage, is over 20, I think it is in New Zealand.
Yeah.
20 is the normal range.
Yeah.
But we would say that that's not optimal. Like our optimal is actually over 30. But if you have, if you're going into pregnancy, or if you have hair loss, then 70 is actually optimal. So again, it all depends on kind of the context and what point of life you're in, or what other symptom you're presenting with in terms of what could be optimal for you.
Yeah, because I think particularly with a few friends that I've got going through pregnancy at the moment, I am interested, have we chats to them about how they're going and things like that, and both of them individually were just saying, oh, I'm so tired, I'm so this, I'm so that. I'm like, oh, have you had your iron tested? They went and got their iron tested. One of them was at 8, one of them was at 9. So the ferritin, as we were saying, what the clinical range deems okay is, above 20. They were at 8 or 9, both of them. But one of them, the one who was at 8, she qualified by being that low for a transfusion. The other one didn't at 9. And at this point, so this was a month ago, she was getting really tired, really run down, just really struggling. Had voiced, how she felt about this, really voiced, wanted to advocate for herself for a transfusion. She was like, look, I'm 1 point away. I'm feeling the symptoms. Can we just do this? And she was put off for a month. She also has a very serious, IBS condition, or like irritable bowel syndrome, which really affects her. She can't risk constipation from like the typically prescribed iron tablets. She definitely cannot be on laxatives. So supplementing that way, because they don't know that you could potentially use another type of iron supplement as well, that's not going to be constipating, but that wasn't an option for her. So it was pretty much just like, let's just wait and see. It's like, really? Like, how is she going to get better? She's just going to have to continue to give up more of her iron for the baby and for blood production and things like that. So a month later, yesterday, she told me she got her transfusion, but I saw her over the weekend and she was pale as a ghost, just absolutely struggling. I think she had to like have almost like bed rest afternoons, and it's like, that wasn't deemed, you know, like they were like, oh yeah, you're lower, but not severe enough, like not 1 point severe enough to qualify for like medical intervention. It's just, it's really interesting to just kind of see those sorts of things, whereas, you know, you and I are just sitting here saying, you know, going into pregnancy you'd want to see more like 70 to 100 so that you've got that room to move back down as you do produce more blood, give the baby iron and things like that.
Absolutely. And I mean, I was just thinking when you were saying then about how there's been some really interesting research come out of University of Canterbury, Professor Julia Rutledge. They've just done a study on high-dose micronutrients as a treatment for postpartum depression. And I'm like, yeah, it just makes so much sense that if you're low nutrient level, then you're more at risk of mental health conditions like postpartum depression. So not only are we not treating this woman who clearly shows that she needs it now, but we're just, again, kicking the can down the beach and being like, oh, well now, like, you know, now I've got this other, like, issue of like postpartum depression, and it's just crazy. And
it all comes down to, okay, well you don't quite qualify for the clinical range, so we won't treat you.
Totally.
And we see this in thyroid, we see this in so many things.
And I think that's like, medicine has to have some parameters, right?
Especially if it's publicly funded, completely.
And we totally get that, but it doesn't mean that it's not the reason why you're not feeling this way. So it might be that, yes, okay, that's the parameter and we have to follow that for actually getting the treatment. We're not saying that you necessarily, we could, you know, get around that if that might be the case, but it's more that what we're saying is that it's not necessarily the reason why you're not feeling like shit. Like if someone, you know, because if her doctor has said, oh no, you're fine, like, you know, you're like within the range, then she might be like, well, what else could I be feeling? Why else could I be feeling like this? And go down another rabbit warren of trying to figure out what it is, when actually it was the iron. She was totally on the money.
She was, and it's not uncommon to hear people be told it's all in your head for certain symptoms. And so I think, like, trust in what you feel and what you know, and it's okay to seek a second opinion as well, because, you know, seeing another doctor, potentially they would have been like, oh gosh, you're low, you know, because they might have more awareness around ferritin levels and energy and things like that too. So another part of this is that there are different reference ranges for different times of your life. So for example, thyroid you just mentioned then, and so thyroid, in terms of if you're trying to conceive, the normal thyroid reference range is much lower than the otherwise normal range. Completely. Which is but also seems bizarre to me that we'd only prioritise a woman's health when she's trying to conceive versus being like, okay, this is not optimal for normal ovulation. Like I understand that there is more to it, that if you're trying to conceive, then you are going to likely end up pregnant soon, and we want to make sure you've got good thyroid levels to support you for the first 20 weeks before the baby can take over that thyroid production. But we do also know that suboptimal thyroid levels can affect your ability to ovulate. So we should be treating that regardless of whether you are trying to conceive or just trying to be a healthy female. Yeah, it's like, exactly. Why do we only focus on optimal nutrition for when we're having a baby, as opposed to like living our life? Like, why can't we live our life in the optimal? Like, that's what I go for. Yeah,
totally. And again, so there is definitely reference ranges for different parts. It just might be that your doctor doesn't know those, or like I've never seen, I don't know, you get your thyroid tested all the time. Does it come back with a reference range for if trying to conceive?
Some of them do, and my doctor was really onto it. She was
she's awesome.
She was awesome, but she was the one who was like, oh, and you're of baby making age, so we need to manage you under 2.5, your TSH under 2.5. And I was like, thank you, like, because at that point I was kind of, it was actually interesting. I'd been referred on from my GP to an endocrinologist, and she was maybe a bit more old school and didn't quite have that same idea, and I'd done my own research and read about that, and I also had the support from my GP around that too. But the endocrinologist was quite like, as I was working to bring my TSH down, I was sitting at like 3.5 at one appointment, and she was like, oh, that's fine. And I actually, me and my doctor, but I left it there because I knew where to pick my battles, and the person who does your prescription was my GP, so we just had that conversation. It's like, cool, I sought specialist help. It wasn't quite like, I had an option to work with a second opinion, and that's where we ended up going. And that's where I feel the best, because a lot of my thyroid symptoms were still very present when my TSH was higher, whereas when it's now managed a lot lower, it's so much better. So yeah, I think that's where kind of like, trust in your gut, advocate for yourself, maybe seek second opinions if you've got the opportunity to. But yeah. So
that's the first two. The first thing is, the reference range is not necessarily for optimal health, but what's normal in the population. The second is that it is just, there are different reference ranges for different times in your life, different things that you're going through, and it might be that the person that's looking at that doesn't know what that reference range is, or that there even is a different reference range for what you're going through. The third thing would be that many of the reference ranges are classified around a disease state rather than what's optimal. So it might be that if you are going back to that case of pre-diabetes, for example, insulin resistance, we talked about gestational diabetes, but pre-diabetes is that the reference range is set around, when is your insulin, let's actually go all those far to type 2 diabetes, and that's basically where the reference range has been set, where you're classified as type 2 diabetes, where your insulin production can no longer keep up with demand. But there is years and years and a whole spectrum of insulin resistance before you get to that point. But the second point before that is pre-diabetes, right? Again, it's where do we classify that your now insulin is too high, higher than what's optimal? But again, that is in the area that we work in. We see people that are presenting with PCOS symptoms driven by insulin resistance way before they get to that pre-diabetes
It's almost
level.
like a barometer, right? It's sometimes when we see these PCOS symptoms presenting, it's like a little indicator of we're working our way down that insulin spectrum now towards pre-diabetes, towards type 2 diabetes, and this is the manifestation of that. So it's but we can catch all this earlier things, put plans and actions in place to really mitigate ever getting anywhere near the far end of the spectrum. And in a general medical situation, we're only collecting the disease state data, and we're only going to recognise when you're already at the end of the spectrum.
Totally.
Yeah.
It's not that there is no reference range that you'd normally look at for what is optimal insulin. It is just, do you yet meet the criteria for pre-diabetes or type 2 diabetes, right? That's the only thing. There's none of the labs that we look at or we know of would give you a reference range for optimal functioning for insulin.
No.
It's only those disease states.
And I guess another way to kind of look at this is, you've probably heard about your HbA1c. That's a commonly batted around biomarker of your health or whatever, and you want to have a lower HbA1c because what it means is essentially how high has your blood sugar been and on average over the last couple of months. And this is where we can see, if you've had consistently higher blood sugar, that shows to us that for the last few months your insulin hasn't been doing its job. Your body is more insulin resistant. You're heading to that diabetic state. But that's only looking at the symptom of the issue, right? We're only looking at, it's only gotten so bad that our blood sugar is so high that it's probably causing damage now to our body, and our pancreas has given up producing enough insulin because it just can't keep up. This is like we said, right down the, where we will then be seeing this as the car's gone over the cliff, the ambulance hasn't arrived yet, but we're just viewing this happening now. So it's really interesting. It's why can't we, go back to that? Let's put a big brick wall in front of the fence so that the car never goes over the edge.
Totally. And that's exactly why we never really look at HbA1c. Yes, if it's high, we then say, okay, that's great, we know that now, let's look at that. But when we're assessing someone's insulin, we will never do an HbA1c because it doesn't tell us, and it's not sensitive enough to tell us, is your insulin high? Is this part of what's causing or contributing to your PCOS symptoms?
Yeah.
And a really phenomenal stat is that HbA1c will miss over 70%, so over like almost 3/4 of people that are even type 2 diabetic, right? And so that's at the end stage. So if you imagine that, how many is it missing that are just a little bit insulin resistant, that it's then affecting your PCOS symptoms? Because we see even just minor insulin resistance driving PCOS symptoms like weight gain, acne, facial and body hair growth, fatigue. And so you might not be classified as like pre-diabetes or diabetic, but it's still having an impact on you. And that's what's important to us, right? That's important when we're trying to improve symptoms, is that we actually want to fix the problem that's causing the symptom, not only once we get to that later stage.
Yeah, so I think that kind of point has really incorporated like the next reason, which is the tests just aren't sensitive enough. Yeah, which is so common.
So common. So especially we see this with testosterone is a really common one. So testosterone, especially when someone's trying to get a diagnosis of PCOS, is that they often come to us and say, I've got symptoms, I've got facial and body hair growth, I've got acne, I'm having irregular cycles, but my testosterone's normal, so therefore I don't have PCOS. And so this is why the actual criteria for diagnosing PCOS does actually include symptoms like facial and body hair loss, acne, because they know that testosterone's not accurate. And what we mean by not sensitive enough is that sensitivity, and when it comes to testing, is how likely is something that's going to show that, there's a percentage where they'll give it a percentage that if it's, how likely is something that's positive always going to show positive? So, for example, a pregnancy test is very highly sensitive, that it will almost never show a negative if it's positive. So it's what's called very sensitive, and it's also very specific for that state, which is pregnancy. So an HCG test for pregnancy is very, very sensitive. People always come to me and say, I've got a pregnancy test, but I don't believe it. It might not be right. And I'm like, well, it's 99.999% that it is, because it's very, very, very sensitive. And so, whereas like testosterone is not really, really sensitive. It will often not pick up when there's high testosterone for a variety of reasons. We've done a whole podcast on this, so we'll link you to that. But that would be one test where it's just like, it's not telling the full story about what's going on in the body. We can see clearly from your symptoms that you've got high testosterone because you've got the facial and body hair growth, hair loss, acne, but it's just that it's not showing in your blood. And there's so many reasons for that, but just remember that that's one of the things.
Another one could be if we're not looking in the right place for the thing. So, for example, cortisol is often like a test that we would look at, and it can be done by the blood, but it's just not that accurate to look at it. So where we see more relevant cortisol testing is through urine. That's where we see a better, more sensitive, I guess, picture of what's happening with the cortisol. So if, your doctor has ordered you a cortisol blood test, we can probably think, well, it might not showcase what we want to see. Or even then, sometimes we don't necessarily see abnormal patterns in cortisol. Cortisol is another one that's probably not super, super sensitive, but not taken maybe from the blood. Other ones, sometimes saliva can be another place that we would actually test some of these biomarkers. So it might be that you're looking in the wrong place for the answer.
Totally. Another one with cortisol specifically, I didn't mention it before, in the optimal versus disease, is that in medicine there are only two problems with cortisol. One is that you've got Addison's disease, which is very, very low cortisol, and one is Cushing's disease, which is very high cortisol. Both of them incredibly rare, and
they're like worst case disease state.
Totally, yeah. And in between that, there is no explanation in medicine for anything in between that. There's no recognised condition or what's optimal, what's not optimal, and so basically just got this void of information about what actually is like proper cortisol. And this is where functional medicine comes in and kind of fills that gap and says, well, we know what's optimal and we can help with that. But if you're feeling like you've got a lot of symptoms of high stress hormone and you've gone to your doctor and they've done a cortisol test and they're saying, yeah, it's fine, then it doesn't necessarily mean that it is. It just means, well, all we can tell you is you don't have Addison's and you don't have Cushing's. That's all we can rule out, but we can't say that it's optimal or fine.
And I think this kind of leads into another reason, which is it might not be taken at the right time either. So cortisol is something that has a particular pattern how it moves in the day. So we typically want to look at cortisol in the morning typically, because that might be the standardized range, or across the whole day is like the better way to see it. So oftentimes it might just be taken in the morning, might be taken at whatever random time you go and get your bloods done, which isn't overly helpful. But what we really want to see is how is it tracked throughout the day as well. So it's really important to be comparing apples with apples, I think, in this, and making sure that, am I checking my cortisol levels against the right timings to kind of look at them, A, from a clinical range, but B, even from an optimal range, to really understand, like, is this what I want to see or not? Yeah.
And so for a cortisol blood test, it should always be taken first thing in the morning, quite early in the morning. By understanding that as well, it shows you why you might not be getting a full picture, even if you do a 24-hour urine cortisol test, which I have done many of in my life. It was like such great fun taking my paper bag of this is before the days of working from home. I remember in my first corporate job, I had to put my bag of urine in my locker and take it to the bathroom every time. It's like a 24-hour urine. Even super interestingly, my 24-hour came back. Maybe it was my blood, but it was say the upper range was 500. My blood cortisol came back at 1500.
Really
but again, so then that's why they did the urine test. But again, because it wasn't Addison's or Cushing's, then it was just oh yeah, you're normal. And I'm I'm 3 times the highest in the normal range. How can this be normal?
And I'm experiencing a lot of symptoms. But no help.
No help. So, but the 24-hour urine, what was probably happening to me now in hindsight was that I had quite high cortisol in the morning, and then also I was really tired and wired, so I probably would have been higher than normal in the night. But on average throughout the day, when we pieced all those, averaged it out across the day, it was still within the normal range, but it was just way too high at either of those points. And so therefore that was still having an effect on my body, but it just wasn't enough that I had these disease states. Interesting enough too, the reason that they gave me, she said it was higher than normal, was because I was on the pill, which can actually increase cortisol, but shouldn't be that much. So I definitely don't agree that was all explained by being on a pill.
But the other hormone that is really commonly taken at the wrong time would be progesterone. So a lot of people present to us and they say, I've got low progesterone, and it's well, you could, but when were we looking at your progesterone? That they're I went in on day 3 or 4 of my cycle, and I got my estrogen and my LH, my FSH, and my progesterone all done. It's cool, your progesterone should be very low there. We wouldn't expect to see any progesterone there, because progesterone is actually only present for the 11, 12 to 14, 15, 16 days post ovulation. So it's only there for a finite time and a higher level, and then it comes back down to baseline pretty much. So it's not that you might have low progesterone right then. You might even have lower progesterone in your luteal phase, but that's not what this test is telling us. This test doesn't showcase to us how your progesterone production is when it's meant to be higher, and that's where we would actually need to look at a different time in your cycle. And again, this is where timing can have a second-fold issue, because particularly in PCOS, it's okay, well, your doctor might say test estrogen, FSH, and LH on day 3 or 4 of your cycle, and on day 21 test progesterone. But if you haven't ovulated at day 21 because your cycle is more 40 or 50 days, then we're still going to see low progesterone. We're not going to see what we would expect to see at day 21, which would be assumed the luteal phase, because you haven't got to the luteal phase yet. You're still in that follicular phase of your cycle. So again, not taken at the right time.
And we see this so often. I see people come to me in tears saying, I've got no progesterone, and I'm it's okay, you're meant to have no progesterone at that time, or very, very low. And then when we do it, it's amazing how much relief that can give them when they're oh my God, thank God there's nothing.
I thought there was a problem.
Yeah,
I thought there was a diagnosis almost for me. And it's just the lack of, I guess, information that's given around the testing, or I think there's a lot of missing feedback that can happen around blood testing that can cause a lot of medical or health
anxiety.
Yeah, totally.
And or either way, either the anxiety because I'm not getting the answers, I do not feel great, I've got these symptoms and I'm really motivated to work on them, but I just need you to tell me.
I don't feel validated that you're hearing about my symptoms, or exactly.
And I just feel brushed off. I just feel that it's everything's normal, therefore but I know that I don't feel normal. Or the opposite, where it's oh my gosh, I'm so worried. Like, and I kind of did, you know, like I was just saying about that cortisol at 1500 is similar kind of, I felt like, oh my gosh, there's something wrong here. But luckily my doctor then did go and do some further testing, was like, okay, there's nothing like...
And walked you through that.
You haven't got any like disease either side of that, but what she couldn't tell me was like, okay, it's probably just not optimal, and I don't have the answers for you, but go and see maybe this specialist who might... they're probably not necessarily in the medical, in terms of, it wasn't necessarily an endocrinologist that could tell me anymore, but someone maybe in more the functional medicine or functional nutrition who could say, okay, it's not optimal, way higher than optimal, and here's what we can do about it.
Yeah. The other reason why it's not that the blood tests necessarily are wrong, but sometimes you might not actually be able to get the blood test that you want. And this happens a lot in a public health situation, because typically in a public health situation, either in some places like, say, the NHS in the UK, quite well funded, quite covered, but not for things that are like superfluous maybe, or what a doctor might deem superfluous. So you might kind of be like, oh, well, I want to look at all of these nutrient levels, and I want to look at this, and I want to understand what my whole thyroid health is doing. But you might go to your doctor there and they'll be like, no, we're just doing the bare minimum, because I can't justify spending all of this NHS money on testing all of these things when I haven't even seen like we kind of have these initial tests that you might get done, which kind of raise a red flag. If you raise a red flag, I'll test further. If not, I'm not doing more. And this happens a lot in New Zealand as well.
I'd say New Zealand, UK, Canada, and sometimes Australia, depending, because the primary health is generally under Medicare there as well, but it can definitely, in our experience, those countries, it can be quite hard to get those tests.
Think the one lucky thing we probably have here in New Zealand, a little bit more, I think Australia too, it's probably a bit more accessible to be able to be like, your doctor might be like, well, you know, say for example, here in New Zealand, vitamin D is not subsidised by the government. So whilst I can get my iron tested, I can get my B12 tested, they don't cost me because the public health system pay for it. If I want to go get my vitamin D tested, that will cost me. But the doctor is like, look, I can't do this for you because I can't justify paying for it because it's not subsidised by the government. But if you're happy to pay for it out of pocket, I can give you this and you can pay for it yourself. Or there is also some really good, the same lab you go to that your doctor sends you to, there's a whole list of tests that you can just pay for to get done for yourself. So the accessibility of getting privately paid done testing is probably a lot better than it maybe is in the NHS, I think, or in the UK, sorry. There's far less companies that are kind of like accessibly testing these sorts of additional things if you wanted to pay out of pocket. So there is a bit of, I hate to say gatekeeping, because there's a purpose and a reason for it. Doctors can't just be going out willy-nilly like testing everyone for everything under the sun when it's really not helpful. And in some cases, for some people, that might cause further health anxiety that maybe doesn't need to be there. There's like, they definitely have their reasoning for it, and like not just be cost, but that could be a reason why you can't learn a lot more. Like I have lots of clients come to me and their TSH is like one notch below going over the clinical range. They're presenting with some other symptoms. I want to understand the full picture. How are their actual thyroid hormone levels? Have they got thyroid antibodies? Because it's probably pretty likely because their mum did and their sister did. And
they've got PCOS, and 25% of people with PCOS have thyroid antibodies, and like all these reasons, right?
All these reasons, but the doctor won't test because they're not quite in that out of range. And so I think that's where it's really difficult to be like, I want to make an informed decision about what's really, or like really understand if these things are at play because there is a family history or whatever. So I just think be aware that even though there are all these blood tests that you can go and get done, it's really common to be denied blood tests as well, and we see that all the time with our clients. And there is a point that we can't do, like unless you pay privately, there's really nothing we can do about that.
Yeah, and there's definitely some ways, like we'll often write referral letters to a doctor and say, hey, look, well, we understand that this is the bounds that you're working in, but is there anything that we can do to get this given these other symptoms? And sometimes there is, and sometimes it's just no. Like I literally, under my requirements of my job, I'm not allowed to order that test unless they meet these requirements. And that's totally understandable. But there's always a way to get them in terms of you want to pay. But there are some times where systems will gatekeep certain certain tests as well. Like I know for patients in the US, they have access to way more tests available to them than what we would in New Zealand, even if we want to pay privately for them. So one I can think of is like in the thyroid reverse T3 doesn't exist in New Zealand as a test.
There's no testing, no lab that actually tests for it.
And so same thing I think with some of the cholesterol tests, more sensitive cholesterol tests like LP-little-a and ApoB. I'm pretty sure we can't get them here yet, but I've got lots of patients that I refer to the testing for in the US. So sometimes it can just be about like where you are and what's available, but a lot of the time there's a way around it.
And I mean, I worked with a client the other day, and one of the really tricky tests is one of those ones we look at how insulin responds to glucose. So like that's sometimes it's like not a very commonly done test. It's quite hard to explain, and sometimes explaining it to your doctor, they just kind of go, not too hard, like no. And so we worked a wee bit to try and find, she was based in Dubai at this point in time, and so we were like, okay, could we have a look at these few labs? And she was like, okay, I'll start with the one that's closest to me. And, you know, she got to the lab, they have a doctor in there, which is like a lab doctor, which was great, willing to prescribe what you were kind of asking for. She said it took a bit of time to really explain, to get them to understand what they wanted, but they were so willing to help her get the testing that they wanted, because the people in the lab are just like, we want to help you, we want to look into this, we want to understand this for you. And then she was like, this is great, like I know I can go back to that lab with anything that I kind of have, because I had such a great experience. So she was like, you know, I could have fought or battled with my doctor to try and get this, which still would have cost me, or actually it was a bit easier to just pay out of pocket and just get that one particular test done. And
this is why health is still comes down to like economics, right? And it's just, if you understand the funding model you're in a whatever country you're in, sometimes it can be much easier to work with that system, because you know, maybe the funding model in Dubai is like, well, like we get paid for pretty much every test that you want to get by your insurer, so yeah, we're happy to roll those tests out, like no problem to us. Or you're paying out of pocket, you know, we're no problem to us.
We're a business.
Whereas in New Zealand, under a public health system, like our doctors have never been
they're not incentivized to test things. They're
definitely not. They're de-incentivized. And so, but also too, they have maybe and same thing in the UK, a perception that patients don't want to pay, and that I don't think that that's always true at all. And so, but they often don't tell you like, okay, no, I can't, like for example, your TSH is not high enough for me to order these following tests under the system, but you're more than welcome to pay for them. This is $40 and this is $40. Like, and I think we miss that context from our doctors under a public health system. So it's just understanding a bit about like what's going on, like what system you're under, and therefore what constraints
and parameters you've got there. Totally.
And that's where, you know, for us working within the system, we can help guide you through that and let you know. And also too, like I just want to finish off by saying that for a lot of the stuff, we don't need blood tests. Like your symptoms show us in many cases so much more than a blood test can, like the testosterone, you know, like how actually facial and body hair growth, we don't need to go and get a testosterone test done for that. We can already see that that's present for you. Same thing that with insulin, there's many symptoms that are clinically significant for insulin resistance. We don't need that. So sometimes it's really nice to have it on paper and be like, yes, okay, I can see absolutely this is what's going on. And there are definitely some things that we can never tell from symptoms, like we can only maybe guess if you're really tired that maybe your iron is a bit low or other nutrients, but we certainly can't, like there are also lots of other causes of fatigue
or low energy. Exactly.
So we can't always tell that from symptoms. There are some tests we really do need to get, but there are also lots of tests that we don't need to get. So don't feel like just because you can't get any testing or that you can't start to improve your symptoms. We can work on so much stuff.
And I think as well, like if you're at a bit of a loss of like, well, where do I start? It's like, well, let's sit down and talk about where you're at, what your symptoms are like, and then we can make a really concise list of things that are actually maybe going to help if we find out. So then you can be really targeted with your testing as well. You know, you don't have to go and try and get everything under the sun from your doctor and it be a bit of a battle and a struggle and feel quite resistant.
Or cost you thousands of dollars.
Exactly. Like we can maybe just look at the key things that are really going to potentially make a difference and go from there. Yeah.
If you're finding value from these podcasts, then we'd be so grateful if you could hit follow on the PCOS Explained podcast. This means that not only you'll get the latest releases, but also that other people are more likely to find this podcast. That's the way the algorithm works. And we all know how important it is to get good information about PCOS. So if you can hit that follow button, it means that people with PCOS that don't know that this podcast exists are more likely to find it. So thank you so much for your help there. Now stand by for our disclaimer. The information contained in this podcast has been prepared for the purpose of providing information, including about the PCOS nutritionist products and services, and is designed to support clients' overall wellness. It is not intended to provide medical advice or designed to rectify, treat, or cure any specific medical conditions or diseases. Nothing stated or shared in our podcast is intended to be and must not be taken to be medical advice. Please seek the advice of professionals as appropriate regarding the evaluation of any specific information, opinion, advice, or content contained in our podcast.